Hello, this is Mr. Ferreira, and I'm going to be talking you through the section on reducing addiction. Now, the specification uses the word reducing addiction. However, we can view this in terms of it being a treatment or an intervention. We sometimes use the word intervention because addiction has high levels of relapse, and so therefore anything to kind of break that cycle is called an intervention. Now, before we look at specifically drug therapy, I'm going to take you through a Facebook video from a TED Talk that you should find quite interesting.
With either heroin or cocaine. The rat will almost always prefer the drugged water and almost always kill itself quite quickly. In the 70s, Bruce Alexander, professor of psychology in Vancouver, comes along and he looks at this experiment and he noticed something. He said, we're putting the rat in an empty cage. It's got nothing to do except use these drugs. Let's try something a bit different. So Professor Alexander built a cage that he called Rat Park, which is basically heaven for rats, right? They've got loads of cheese, they've got loads of colored balls, they've got loads of tunnels. Crucially, they've got loads of friends, they can have loads of sex, and they've got both the water bottles, the normal water and the drugged water. But here's the fascinating thing. In Rat Park, they don't like the drugged water. They almost never use it. None of them ever use it compulsively. None of them ever overdose. You go from almost 100% overdose when they're isolated to 0% overdose when they have happy and connected lives. What if addiction isn't about your chemical hooks? What if addiction is about your cage? What if addiction is an adaptation to your environment? This has really significant implications. The most obvious implications are for the war on drugs, right? We punish addicts, we shame them, we give them criminal records, we put barriers between them reconnecting. Now, there's a place that decided to do the exact opposite, and I went there to see how it worked. In the year 2000, Portugal had one of the worst drug problems in Europe. So one day, the Prime Minister and the leader of the opposition got together, set up a panel of scientists and doctors to figure out what would genuinely solve the problem. And they came back and they said, decriminalize all drugs, from cannabis to crack. But, and this is the crucial next step, take all the money we used to spend on cutting addicts off, on disconnecting them, and spend it instead on reconnecting them with the society. But the biggest thing they did was the complete opposite of what we do. A massive program of job creation for addicts and microloans for addicts to set up small businesses. And when I went and met the addicts in Portugal, it's fascinating. What they said is, as they rediscovered purpose, they rediscovered bonds and relationships with the wider society, and the results are in. Injecting drug use is down in Portugal, according to the British Journal of Criminology, by 50%. Overdose is massively down. HIV is massively down among addicts. Addiction in every study is significantly down. We talk all the time in addiction about individual recovery, and it's right to talk about that. But we need to talk much more about social recovery. We created a society where, for a lot of us, life looks a whole lot more like that isolated cage and a whole lot less like Rat Park. What I try to do now, and I can't tell you I do it consistently, and I can't tell you it's easy, is to say to the addicts in my life that I want to deepen the connection with them, to say to them, I love you, whether you're using or you're not, and if you need me, I'll come and sit with you, because I love you and I don't want you to be alone or to feel alone. And I think the core of that message, you're not alone, we love you, has to be at every level of how we respond to addicts, socially, politically, and individually. Because the opposite of addiction is not sobriety. The opposite of addiction is connection.
I hope you found that video fascinating. I certainly do. It's the reason I played it is just for you to think about this idea, the irony of giving a drug addict a drug. It comes from this idea that addiction is this chemical hook that we take a substance and it kind of connects us to it, and so therefore we have to give an addict something that they need in order to stop having that chemical hook. Now, when we start looking at the specifics of what they ask us to do, it is quite vague that to simply say drug therapy. So therefore, I'm going to talk you through a number of drugs. We also know that any drug therapy is called a biological intervention. There's also another word that we call it as pharmacological. It's simply that we give a drug to help overcome their addiction. Now, of course, we are familiar with doing this for heroin. and nicotine and alcohol, but of course it can also be used for behavioral addiction as well. Now, the first drug we're going to look at is called methadone. It's important for us to kind of know a name, but also we see that it's called an agonist or agonist maintenance treatment. Now, of course, an agonist is something which is like the substance, so like the addiction. Okay, and we saw this previously when we had an antagonist, which was the opposite. So in other words, by giving the addict this substance, it looks like that, a nice little green like cough syrup type mixture, it's going to give them a similar effect to the drug that they are familiar with, okay, because it binds to the neuron receptors and activates them in the same way, okay, so it's going to give them a similar effect. You could ask the question, why are we going to do this? Of course, it's a safer drug to give than heroin, okay, so it says this treatment is usually given to opiate addicts such as heroin, but of course, it says here it's used to manage the heroin withdrawal symptoms. Okay, maybe the question still remains, well, kind of why would we give them another drug like heroin? Well, first of all, we need to kind of recognize that heroin is often a very extreme drug where the highs are very high and the lows are very low. We also know that the people who sell drugs are often putting chemicals within them to kind of bulk out their powder to make kind of more money, and it's not a very kind of good kind of place to be, because often a heroin addict, because of something like the war on drugs, is usually outcast, put into some kind of dingy place. It's unsafe, the needles are unsafe, the environment's unsafe. So therefore, giving them this long-acting synthetic opiate, okay, long-acting is also counteracting their kind of extreme highs and lows. It allows the patient to kind of come off heroin and onto something safer. And because it doesn't give the same effect as heroin, you can ultimately wean them off the methadone as well. So it says here, methadone mimics the effects of heroin. That's kind of why it's an agonist. It also has fewer side effects, which is good. And of course, it's cleaner compared to the substance or heroin. Now, what we would hope the purpose of the agonist would be is to kind of make the addict able to be stable, maybe kind of enter therapy, maybe start some kind of job or something along those lines. Some of you might have seen a film called A Street Cat Named Bob, and the main character in there is trying to get his life together, and he's on an agonist treatment for his heroin addiction. Now, I've got another video to show you. This kind of does explain some of the aspects of methadone. It's also proposing potentially that some people might remain on the agonist, methadone, for an extended period. It would be a bit like taking a kind of a medicine to kind of help them cope in everyday life. So let's have a look at this.
Opiate addiction is really different than addiction to other substances. It has a different effect on your brain chemistry. Abstinence-based treatment programs don't address that very effectively, so you end up only getting half the treatment that you need. The treatments that you've been receiving in the past, often for opiate addiction, are not the right ones. But then you, as the person who hasn't done well in that treatment, get blamed for not doing well in it, when in fact it's not the right thing. This is the right place for you. So what we do is we give people what we're calling replacement therapies, methadone and now buprenorphine, that goes to these same receptor sites in your brain and stimulates them. But the difference between that and the drugs that you're using on the street are several. One is the drugs that we give you in replacement therapy, if they have any buzz, it's very small, and it usually only lasts for a little while. It goes away. People become tolerant to that. They're long-acting, so they stay in your blood at a steady level all across the day. Right? When you boot in heroin, it's like up and down, right? They're short acting and it's awful. And you have to keep using periodically across the day in order not to be sick. Buprenorphine and methadone, nice and level all the time. That tends not to hurt your brain chemistry in the same way. It's that rapid up and down stuff that tends to do that to you. So what it does is it's sort of like being diabetic and taking insulin that regulates your blood sugar. You're taking a drug that regulates a natural neurochemical system that you need to have on board every day in order to feel great, in order to feel well. One thing I will tell you, though, is that this is not a magic bullet, and those of you who've been on it a while know this. You can't make little tiny tweaks in it, right? If you have a bad day, and the amount you have on board is not enough to sort of compensate for that and make you feel better, I can't give you a little bit more methadone at that moment, and like you could with insulin if your blood sugar was wrong, so that you feel better that day, because it takes 2 or 3 days for you to get an effect from the methadone. And so what would happen over time is you'd get on huge amounts of the medication with us trying to always make you feel better that day. So part of your job in a treatment program like this is to do the work that you need to do to learn how to take care of yourself in a way that will help you deal with that part of the days that aren't good. But it's possible to do, and it works really well. You can learn techniques that will help you do that.
Now, I hope you enjoyed that. I suppose he kind of makes it quite clear that you can't use a long-acting drug and just give a little bit of it to make you feel better. But he does kind of brush off about the fact that you got to find ways to deal with this. Another thing I'm going to kind of question is the whole outpatient setting, trying to get an unreliable person who's addicted to some kind of drug to regularly kind of go to a chemist and kind of get this particular substance. However, that's one of the drugs that we can have a look at, and it's certainly used very commonly in the NHS. Now, the second drug is called naltrexone. Now, this is not as common, or I find it harder to find on the NHS, but this is called an antagonist. In other words, it does the opposite of what the drug does because it blocks. Now, of course, one of the things you can talk about is that if the addiction doesn't have the desired effect, if it doesn't kind of give that instant relief, then the addict may not turn to that particular thing to become addicted to it because it's not doing the thing. And in some ways, this is exactly what this is attempting to do, is to block kind of the pleasure that you would receive from the drug. Now, of course, this is given in a slightly different context. It's also outpatient. Okay, and we can see now there's also behavioral addictions that we can use it for, and the video that I have later is talking about an alcoholic. Now, the other thing about naltrexone is we often would use this after detoxification. Now, of course, that's a little bit unclear in terms of, say, heroin, how they're going to detoxify, and there are kind of medical treatments, including methadone, can help a person kind of come off the heroin. But because kind of coming clean, it's often really difficult, and so therefore the addict kind of returns to that kind of easy fix. Naltrexone kind of has a purpose there. So what it does here is that it's also long acting. So this is the person who's kind of gone through some kind of rehabilitation program, is clean of the drug, but they kind of take the particular tablet. It's a tablet, and it kind of helps them to kind of get a different kind of reaction from if they return back to the substance that they were addicted to, or the behavior that they were addicted to. So in other words, when you stop the pleasure, you kind of have no desire to return. So it says here, reducing the rewarding and reinforcing properties. Okay, so you can see that clearly one of the aspects of addiction was the quick and easy access to mood change. So of course this won't do it. So if you don't have the desired effect, then it makes it kind of undesirable. So therefore the reward nature of taking the drug or doing the gambling or drinking is broken, and the person then soon kind of learns very quickly not to participate in that particular behavior. We also would hope at this particular stage that they can receive counselling. So of course, that's not part of the drug therapy aspect of it. You could use it as a criticism that if you don't receive counselling, you're never going to be dealing with the underlying issues that there are. Now, of course, I do have a video for this. It's quite an American video, but it certainly is interesting. It's looking at recovering alcoholics.
A local woman's addiction to alcohol was so intense she used to consume 14 to 22 drinks a day.
She tried every approach to stay sober until she found a legal and safe way to break her craving. Tonight in Cover Story, News Channel 5's Kay Quinn shows us how a prescription drug is changing the lives of many people with different substance abuse problems. Kay?
Deanne and Mike, it's called naltrexone, and it costs on average about $3.50 a pill. Most insurance covers it, and the recovering alcoholics I spoke with say it's worth it. This 45-year-old woman begins each day with a pill, a twice-daily dose of a prescription drug called naltrexone. This is how she used to start the day.
I'd have to hold the glass like this and hold the bottle kind of like this, and I would just basically drink throughout the rest of the day.
Because of the stigma of addiction, she doesn't want to use her real name and asks to be called Tracy. She's been an alcoholic since she was 15. The last 3 years of her addiction were the most disabling.
The only way I can describe it is it was like my oxygen. I had to have it.
The turning point came 14 months ago. Her mother found Assisted Recovery Center of America. Owner Percy Menzies routinely recommends the FDA-approved drug naltrexone along with regular therapy for people with hard-to-treat addiction.
Some of them have spent 5-6 attempts at getting well. And they say, why did you not hear about this program? Why did you not hear about this medication? And that's the question they ask us time and time again. It's almost like a lifesaver.
Menzies says society disapproves of relying on pills for problems, but he views addiction like a chronic disease similar to diabetes.
As long as it works.
John Wright says he failed the 12-step approach to treating alcoholism. He turned to naltrexone just as his drinking began to erode his personal and professional life.
And I was very lucky because I managed to stay out of most trouble areas legally, medically, financially.
As long as you take the medication, we have a 100% success rate.
Alcoholics.
Psychiatrist Dr. Charles Conway says that is the stumbling block that's kept many in the medical establishment from prescribing naltrexone for large numbers of addicts. Getting them to take a daily dose of the medicine can be a challenge.
It is somewhat controversial. I think it has gained general acceptance as an add-on treatment. I don't think anyone in the medical profession or those in psychiatry in particular would look at it as a silver bullet or something that's going to cure alcoholism.
Dr. Cicero says it works in alcoholics by blocking the effects of endorphins on the body, a so-called Teflon coating for the brain that doesn't allow alcohol and even certain drugs to penetrate and create a high or a craving. If a person were to drink while taking it, they could still get intoxicated, but would likely stop after one drink because there's no high. While it helps alcoholics, it's even more effective for people addicted to heroin, morphine, codeine, methadone, Vicodin, OxyContin, and Demerol, just to name a few.
I never, ever, ever would have thought 2 years ago that I could care so little about something that was so important to me.
Tracy says her cravings are gone, and she's convinced naltrexone is the key to her future sobriety.
You can still get intoxicated, you will still slur, you'll still stumble and do stupid stuff, but it's still going to impair me, but it's not going to give me the feeling that it did before. I felt so odd when I was on naltrexone and drank that I thought, I don't really care about this anymore.
Now, naltrexone has even caught the imagination of the courts. A St. Charles judge recommends it to some people completing programs in drug court. And in Anchorage, Alaska, a judge orders repeat drunken drivers to take naltrexone.
But you have to take it every day. Are there other drugs that are approved for addiction?
There are a handful of other drugs, and some work specifically for people addicted to drugs, and some also address alcohol, people addicted to alcohol. One is Antabuse, the one you may have heard of that makes people very sick if they drink. But there are ways to help people out there besides just naltrexone, just a 12-step program. There are some options. People should look around.
Okay, so that video is certainly very interesting. Hopefully you saw how that woman said how alcohol is like oxygen, and then when she was on naltrexone, she kind of felt so odd, and that's kind of effectively kind of how it works. Now, what they mentioned in that particular kind of video was also this disulfiram drug. It's called Antabuse. It's a drug that makes a person sick, so therefore this is called an aversive agent. So the purpose of this is to literally give you an unpleasant consequence of your addictive behavior. Now, this is only specific to alcohol, and therefore you need to kind of consider the question before you use it. So you have this unpleasant reaction when you use it with the drug, which is alcohol, makes you feel sick, and therefore you don't want to drink. And of course, if this is done repeatedly, of course, it replaces the positive reinforcement that the alcohol would have given you before. Okay, see the common name there, antabuse. It used to be a drug, but we see now that you can also get an implant, and certainly something which does kind of make sense for somebody who's desperately tied to alcoholism and can't stop. So then I think it's the last drug therapy that we can look at is called nicotine replacement therapy, or we just simply call it NRT. This is something which you have been probably heard of. It's kind of a patch or some kind of chewing gum or kind of inhaler or something that a person who's trying to quit smoking takes. So we see that what we're trying to break here is the use of cigarettes, because tobacco is the carcinogenic, kind of lighting it up and putting it into your lungs is kind of what is harmful. So this allows you to replace the nicotine that you would normally get from a cigarette. So this is very similar to the idea of methadone. You're giving something clean that is controlled, and it kind of binds the same receptors as what your nicotine would do in terms of a cigarette. And so, of course, what it does, it's means that you can take less nicotine because you can control it, and hopefully over time you can reduce it as well. So there we have kind of very kind of simple drug ideas. Look, there's going to be so much about this that we can be critical of. Of course, there's going to be research support as well, but we just need to kind of think can we name the drug? Can we explain how they are used? And certainly that should help us in order to kind of answer any questions that we may have. So let's look at some of the evaluation points that we have. And I suppose the biggest issue with giving any form of addict, simply giving them a drug, is of course it's ignoring the underlying reasons for the addiction. And I would certainly say from my own experience that the addicts that I've met, there certainly seems to be a story, as something that's part of their addiction. So if we ignore this and just treat the symptoms, then we pretty much are not going to help them in the long run. Now, of course, for some people, it may be that they do need that physical help of a drug to help them overcome, but you can see how potentially this could be problematic. It also means that as soon as the person stops the drug, they return to their addictive behavior. In fact, a lot of overdose happens at this particular point, because if they have been reducing their drug use, certainly the bodies do adjust due to tolerance and dependence. And of course, then they take more drugs than potentially their body can handle, and that's where overdoses happen. However, we don't need to be overly critical to an extent of totally ignoring drug therapies, because there are people who do believe that having some kind of substitute is important for stabilizing behavior. Let's think about the realities of an addict. They may not be able to maintain relationships, certainly may not be able to maintain job or any other form of security. And so the whole isolation issue is a real issue for an addict. And so therefore, if they're under some kind of treatment that is not as harsh or as difficult, or they don't have to spend time kind of getting the drug because it's given to them, they might be able to kind of work. And so we look at something like the street cat named Bob certainly does highlight that, that, you know, trying to find a purpose within the addict's life. However, what we do need to recognize here is that it probably only really works if they're able to kind of seek help in some ways. But of course, you can see from this point, it says that if I can take away some of the risky behaviors, I might be able to deal with some of the other things. Now, I've just got the mention of the LUTI there, just to tell you that there are other forms of drugs that they can use. It's a bit more expensive, and I'm not sure whether every country would actually use this. Finally, just to kind of refer to a couple of things, Callahan is quite kind of positive about it, but he does talk about preventing them from kind of drinking or taking kind of lesser drugs and stuff like that. And if you are interested in this, there's several different Russell Brand documentaries, and certainly he's kind of, he's got a couple of other videos out there, and he is an abstinence-based treatment person. He will say, exactly what I've been saying, kind of why give an addict a drug, because that's problematic. And so certainly we need to kind of look at this positive point and look at it in terms of kind of the context of an addict as well. Kind of moving on, of course, the limitations, and there's going to be lots of them. I think most of them were about the fact that it's all about an outpatient setting, but we also find that actually methadone itself can be addictive and can cause deaths. It's not necessarily as prevalent as other hard drugs, but certainly it's not perfect by any means. And so we see that the concern about methadone is possibly the outpatient. So it says here that the consumption is unsupervised. Okay, so this is the outpatient setting. You've got to worry about kind of getting an addict into the chemist every day. I mean, you probably over lockdown, if you kind of didn't have a purpose of getting up in the morning, probably really struggled to get up kind of before lunch. So you're going to get an addict to go to the chemist regularly to get the methadone. They're also gagging for the other drugs because they still want to take the other drugs, and so they could sell it, they could try and do something with it. It's not really worth much, but of course you never know what's going to happen. So methadone is often quite problematic, and we can certainly see kind of lots of reasons behind this. If we are writing something specifically on smoking and we want to refer to NRT, there does seem to be quite a lot of evidence that it does work. And so this particular research says here that the effectiveness was compared to placebo, and quite literally the participants were given either the NRT or placebo and kind of see kind of how it worked for them. They had several different trials, and what we find is it says that they concluded that all the different types of NRT were effective. Okay, so we do have lots of kind of information that kind of helps us. I mean, it does ignore some of the psychological aspects of smoking. Smokers want to smoke a cigarette. However, if you are trying to give up smoking, certainly something like gum or some kind of patch and stuff like that will certainly work. And what is key to this particular research, it says independent of any additional support. So in other words, literally it works. Okay, it has a physical effect on a person and it does work. Now, coming near the end, I kind of wanted to have a look at specifically naltrexone. Now, of course, I haven't got a generic kind of point, this whole kind of point that it's reductionist or any of those type of things. But of course, I'm hoping that you're able to have a look at this concept. It's potentially quite deterministic, kind of saying that if you take this drug, you will be able to come clear. But of course, people have choices, they have life situations and other factors. But one of the things that I always thought about when I was looking at naltrexone is the fact that it's taking away pleasure. It's affecting parts of your brain. And so not the best point I've made, but it says can make fun activities uninspiring. Okay, so in other words, what are you prepared to trade off? Now, of course, those two alcoholics we saw in that video, they clearly got to the point where life was pretty much falling apart, and they're prepared to trade that off to kind of have boring lives in order to not be an alcoholic. Okay, and it's because this brain reward system is quite crude. We can't pinpoint specifically just that alcoholic's part of the brain or just that gambler's part of the brain. We're certainly kind of still kind of learning a bit more about that. So it says, by stopping the brain from releasing dopamine, it could stop a patient from having pleasure in other areas of life. You know, and sometimes that's what makes life meaningful, kind of receiving pleasure from friends, from sport, from sex, from any of those types of things. And of course, what this might mean is that the person doesn't want to take the drug anymore because it kind of doesn't make them feel fulfilled. And of course, that's going to be the biggest weakness. As soon as they stop taking the treatment, they might kind of go back, and so therefore not continuing means is kind of a problem. Now, I know with all of these points you can expand on them. I certainly would recommend you look at the chapter in the textbook and certainly kind of help you kind of write something that's certainly kind of a peak paragraph and certainly kind of argumentative, certainly in a discussion type of question. Now, just to end off with, I do have an actual 60-mark question. This is something which we need to be prepared for. So they could ask us on drug therapies. They could ask us on any of the types of therapies, but sometimes they use kind of vague terminology. So what they said is one biological intervention. Okay. Now, of course, this is really, really important that you kind of make it clear that the biological intervention is drug therapies and not naltrexone or not methadone, because that is a little bit too restricting. You want to be able to write about all the types of drug therapies in order to kind of say that's the treatment, it's drug treatment, and therefore it kind of makes your evaluation quite important. We also see the word effectiveness. So of course we could talk about if a drug is effective, like methadone, if people do stick to it, if it's appropriate in an outpatient setting as well. That's another way of being kind of critical of any form of treatment. So there we go. I hope you've enjoyed this video on reducing addiction, looking specifically at drug therapies. I'll continue the series when you finish your exams, and I hope that you're well. Okay, thank you very much, and good night.